I'm Candy Stockton. I am the health officer for Humboldt County, for those of you who have not met me yet. Welcome, we're so happy to have you here today. I see a lot of younger faces in the room, and so syphilis has probably always been on your radar. I also see some faces that look closer to my age, and I can remember back 20 years ago when we used to talk about how there was starting to be a little blip and increase in cases, and we were worried about a possible future where there might be a congenital syphilis case on our horizon. Now, unfortunately, Humboldt County has been identified as one of the counties in the state with the highest rates of congenital syphilis. So we're really glad you guys are here to learn more about testing and treatment today, because we want to try and turn that around. We know that in spite of the fact that we have really high rates of many types of complications in this area, that we do a lot of amazing work in this area as well, and I want to recognize that. But I think that there is room for us to look at revisiting how we're handling this problem. And with that, I'm going to say a special thank you to CDPH and California Prevention Training Center, Prevention Training Center. Thank you. Who came up and are doing this training for us today. This is Dr. Brian Hamst. I had it right until I got nervous. Who is a family medicine physician and the fellow with the STI fellow with CDPH, and Dr. Kathleen Jacobson will be here with us in a few minutes. But Dr. Hans is going to go ahead and get us started today. And I am supposed to tell you three things. One, there are a lot of great resources in the back, and I verified that personally. There really are, including laminated posters on treatment protocols that you could post in your doctor's offices, because we all know, those of you who are nurses here representing your teams today, that doctors don't really keep track of things. So putting that up there where they can see it, super helpful. The second one is, if you didn't register, we're super happy to have you here, and can you raise your hand so we can thank you and make sure we get you registered? All right, so somebody identified you from the back of the room, and we'll be helping you out with that because we want you to get credit for being here. And the last one is this sheet right here. I know you can all read it from where you're sitting, is on the back table, and at the bottom is the very important information about where to watch for the post-training email so that you can fill out the evaluation and get credit for your time here today. Okay? All right, well, with that, I'll hand it over to Dr. Hans. Thank you so much for being here.
Thank you, Andy. I have a tendency to talk quiet and mumble, so please just tell me if that's happening and you can't hear me. Can everyone hear me though? Thumbs up from the back? Okay. Again, my name's Wyatt. I'm the STI fellow with CDPH and CAPTC, and I'm joined today by Kathleen Jacobson, who just came in with us, and she'll have her own introduction after I do my presentation. But today we're just giving you a case-based update on syphilis. And let me see if I can advance my slides. Just for a few learning objectives, we'd like you to take away a better understanding of the epidemiology for congenital syphilis, as well as primary, secondary, and early syphilis in Northern California and in California in general. And then take away a better understanding of how to describe syphilis staging, treatment, and follow-up. We'll learn to compare traditional and reverse screening algorithms. And then we'll also apply California's expanded syphilis screening recommendations during pregnancy in a case-based format. And just to begin with epidemiology, as we all are probably all aware at this point, the trends in syphilis are not looking great in California. These are two graphs that show primary syphilis, or actually syphilis of all stages in the female population, as well as syphilis, congenital syphilis over the last 10 years or so. As you can see in the female population, the numbers have increased 1,035% over the last 10 years. And then for congenital syphilis, there's been a 1,764% increase in numbers. Just to give you numbers or give you something to think about, in 2012, there were 33 congenital syphilis cases, one of which resulted in stillbirth. But as of 2022, or in 2022, there were 615 congenital syphilis cases, and 48 of those resulted in stillbirth, and 11 resulted in neonatal death. So a really unfortunate increase that we're seeing. This is a graph that demonstrates the incidence of early syphilis. We're describing early syphilis as primary, secondary, and early asymptomatic syphilis. over the last several decades, from 1941 until 2021. And you can see it's been extremely variable, but we had a low in the early 2000s. But since then, we've had a very steady increase in both of the US and in California. And the increase in California has been more rapid than in other parts of the US. This looks more specifically at California. These are two maps comparing cases in California as well as the rates in California. As you can see, the Northern California region is outlined in red. And if you just look at cases, there's overall a lower number of cases as compared to the rest of California. But when we look at rates, which are rates per 100,000 persons, they're actually comparable in many counties. And this ranks all of the counties minus the ones that are lower just because they couldn't fit on here. But it ranks most of the counties in California by their syphilis incidence, early syphilis incidence. And it compares that to the state average rate, which is 43.9. And as you can see, there's 14 counties that reach or exceed that average rate, and 7 of those are in Northern California. They include Lake, Yuba, Sutter, Butte, Tehama, Shasta, and Siskiyou. And this is another way of looking at that incidence and how it's increased in Northern California over the last 10 years. You can see Northern California, let me see, okay, here we go, was actually the lowest incidence in all of California as of 2012, but it's very quickly surpassed most other regions in California to become the second highest incidence in the state, only second to San Francisco. And again, that's for early syphilis incidence. And these are similar maps comparing the incidence in the female population to the incidence in the male population. As you can see, there's higher incidence in most counties in the Northern California region for the female population than the male population, with those darker county or darker purple coloring. And you can see that for Humboldt as well. This is another interesting way to look at the overall numbers of early syphilis in the Northern California region. And this graph shows by year the sex of the person who is infected as well as the sex of their sex partners. And I want to draw your attention specifically to those that are female who are infected with early syphilis, which is this kind of fuchsia color or red color here. It's very quickly increasing, but also what's interesting is if you look at other areas in the state, the large majority of those infections are among the MSM and MSMW population. But in the Northern California region, we see a very large increase in the female population, and this is very different than in other parts of the state. These are the trends for congenital syphilis throughout the US as well as California. Similar to the trends for early syphilis, you can see there's a lot of variability from the 1960s until 2021. But the US and California usually stick in line with each other pretty closely. And this compares to the Healthy People 2030 objective. But similarly, as you can see, in 2010, there was a very steep increase in the incidence for congenital syphilis in both the US and in California. But in California, it's been a much steeper increase. And both of these are vastly above the 2030 goal. These are similar maps to the maps for early syphilis that look at both cases and rates for congenital syphilis in the Northern California area. As you can see, the cases overall are on the lower end if you compare to the Southern California region with those lighter pink colors, but the rates are actually comparable. As you can see, Humboldt has a rate of at least 130 per 100,000 cases, or for 100,000 persons. And this is a similar graph that ranks all of the counties by their congenital syphilis incidence, and compares that to the state average rate, which is 120 per 100,000 live births. And you can see there's 20 counties that meet or exceed that state average, and 7 of those are in Northern California, which include Yuba, Shasta, Lake, Sutter, Butte, Humboldt, and Tehama. And as you might imagine, there's some association between the rates in the female reproductive age group and the rates of congenital syphilis. This is a map that looks at the incidence of early syphilis in a female group who's of reproductive age, and it compares it to the maps for congenital syphilis. While they don't line up perfectly, you can see, especially in those central Northern California regions where there's high incidence, you also see high incidence of congenital syphilis. That's it for the epi portion. Since we're all here in person, does anyone have questions about that? We can also save them till the end too. Okay, well, if anyone has questions throughout, you're welcome to interrupt me. I want this to be interactive, and I'll have questions for you too. But during this presentation, we'll be going through a case. I'm hoping this can help kind of solidify everything we're learning and apply it to a patient, and hopefully a patient that you might see as someone coming or encountering in kind of your everyday work. So to start with this case, we have a 19-year-old G1P0 woman presenting to primary care appointment after having a positive home pregnancy test. Her last menstrual period was 10 weeks ago, but it was lighter than usual, and her periods are irregular at baseline. She has a positive pregnancy test in clinic, and she would like to continue her pregnancy. She has a past medical history of herpes and eczema. She has no known allergies to medications, and she takes acyclovir and hydrocortisone PRN, and she has no family history. And for social history, she has one male partner. They're on again, off again. He's currently in jail, but he's due to be released soon. And the provider that she's seeing in clinic today doesn't do primary care or doesn't do prenatal care, and so they place a referral to the local OBGYN, and they also order a dating ultrasound, which shows a singleton pregnancy with a normal anatomic survey, a gestational age of 18 weeks and 6 days, and a placenta that is normal. And again, the provider doesn't do prenatal care, and so doesn't order any prenatal labs. And my first question for you, we'll have many questions throughout this, and we don't have an audience response mechanism, but I want you to kind of think of the answer in your head, and then we'll go over all the answers, okay? And so the first of those is, when should a pregnant person be screened for syphilis? Possible answers include A, never, B, during the first trimester, C, during the first and third trimester only, D, during the first trimester, third trimester, and at delivery, unless they are low risk and have a documented negative screen during the third trimester, or E, don't know. D, yes. Okay, I love the audience response. Okay, yeah, the answer is D. And you probably could have guessed just from the length of the answer, but that is correct. And this is per California's expanded syphilis screening guidelines, which were released in 2020, and we'll go over that in the next few slides. And I'll also go over California Health and Safety Code, which helps support these recommendations. So here is a summary slide of the CDPH's 2020 expanded syphilis screening recommendations. And I just want to draw your attention to the first one of those, which is at the top in the orange, which reads, expanded prenatal syphilis screening with all pregnant patients tested at least twice and screening at delivery. This doesn't go into many specifics, but if you look at the rest of this document, it does explain what that means. And that means all pregnant persons at confirmation of pregnancy or first prenatal visit should have a screening that may or may not happen in the first trimester, but it should be at the first visit. And They should have a second screening during their third trimester labs, which are usually around 28 weeks. That's everyone should have those 2 screenings in California. And then persons should be retested or rescreened at delivery unless they are considered low risk and have a documented negative screen during the third trimester. And you might be wondering, well, what's low risk? I'm going to define high risk for you, and anyone who doesn't fall in this category can be considered low risk. A high risk individual is either one, living in a high risk community. Unfortunately, 2/3 of communities or local health jurisdictions in California are considered high risk. You can see in this map to the right, that the county or the local health jurisdictions in orange have higher congenital syphilis morbidity in California and are considered high risk. And then the second criteria for being high risk is having sociodemographic characteristics associated with congenital syphilis. And those characteristics can be broken down in many ways, but I wanted to talk about race and ethnicity and what we're seeing as far as trends in congenital syphilis. So this looks at all the cases of congenital syphilis in 2021 and breaks it down by the race of the mothers. And you can see that the largest burden of congenital syphilis was affecting birthing parents of Hispanic ethnicity. And that was about 45, a little over 45% were Hispanic or Latinx. That's the overall number. The graph on the right actually shows the same thing, just with the total number, and that was a little over 250 cases of congenital syphilis. But when we look at the rates, so that's total numbers. When we look at the rates, the highest rate of congenital syphilis is among the Black and African American birthing parent community. And the rate is 300 per, a little over 300 per 100,000 live births. And that's quite stark compared to the state average incidence, which is 120 per 100,000 live births. And this just really draws your attention to the importance of centering racial equity in the work we do for congenital syphilis. Other than race and ethnicity, there are other non-race ethnicity sociodemographic characteristics which make somebody more vulnerable to congenital syphilis or infection during pregnancy. This data is also, I believe, from 2021. And this looks at different sociodemographic characteristics among mothers who were affected by congenital syphilis. As you can see, a little over 50% of those mothers had no prenatal care during their pregnancy. 49% had a history of methamphetamine use. Another 29% had a history of experiencing homelessness, and another 4% had a history of incarceration. And so those are all things to think about when you see somebody in clinic or when you see somebody in labor delivery specifically and are thinking about screening them again at delivery. And you might be wondering, why do we screen so frequently? There's several reasons. The first of those is that the vertical transmission of syphilis, if somebody goes untreated, is extremely high. 80% of pregnant persons who don't get treatment during pregnancy will pass that infection to the fetus. And that can happen at any stage during syphilis infection, so primary, secondary, late, and tertiary. And it can happen at any stage during pregnancy. Additionally, congenital syphilis has a very high morbidity. We'll learn more about that in the coming slides. And screening can accurately detect infection during pregnancy. Early detection and treatment can reduce morbidity, and the harms of screening and treatment in pregnancy are minimal. There are laws written into California's Health and Safety Code that help support these expanded screening recommendations. This comes from the Health and Safety Code, and it reads that every licensed physician engaged in prenatal care shall obtain a blood specimen at the time of first professional visit or within 10 days. It then goes on to say that the blood specimen shall be submitted to test for syphilis. Okay, that was California law and the expanded syphilis screening guidelines. We'll come back to that in a little bit, but I did want to go over some basics for syphilis, just so we have a strong foundation for the infection. And so syphilis is caused by Treponema pallidum, and that's a spirochete bacterium. And transmission is through direct contact with an infectious lesion. And it can also be bloodborne and transmitted from mother to fetus, as we have already learned. The incubation period, so that is time from contact to developing symptoms, is usually 3 to 4 weeks, but it can range anywhere from 10 days to 90 days. So it's quite variable, actually. And the infection, the bacterium causes a systemic infection, which is characterized by episodes of active disease interrupted by periods of latent infection. We can see here in the diagram to the right, this just shows the kind of the life cycle, if you will, of syphilis, and it shows the bacterium entering the body. This can actually happen through any site of inoculation. It does not have to be on the genitalia. It then usually goes on to cause a chancre at the site of inoculation, and then it enters the lymphatic system, after which it will enter the rest of the body to infect the other organs. And this slide shows the natural history for syphilis. We're going to revisit this multiple times throughout this presentation, but I just want to show it to you now. Again, syphilis is characterized by stages of active symptomatic disease, which are primary and secondary syphilis, interrupted by latent infection or asymptomatic disease. There are many complications of syphilis. We already talked about congenital syphilis, which if somebody goes untreated and they become pregnant, it happens 80% of the time. And it can happen at any of these stages, but there's also neurosyphilis, ocular syphilis, and otic syphilis, which can be complications. That can also happen at any stage of disease. We'll come back to this more to talk about each of those stages with you. Before we move on, I do want to talk a little bit about the diagnosis of syphilis and how do we interpret syphilis testing, because it can be fairly complicated. Before we jump into that, I wanted to ask you a question. That is, in which laboratory scenario would you be most concerned for active syphilis infection? Again, we don't have a ton of history here, but just based on labs, what would you say is most concerning? A patient with a history of syphilis who is TPPA reactive and has an RPR of 1 to 2, and their RPR 3 months ago was 1 to 1. B, a pregnant patient with a newly reactive EIA, but non-reactive RPR and confirmatory TPPA, also non-reactive, and their testing several weeks later confirmed the same results. And C, a patient with a history of syphilis who is TPPA reactive and has an RPR of 1 to 64. Their RPR was 1 to 8 3 months ago. Yes, I heard C. Everyone in agreement with C? Yes. Okay, we'll go over each of these. C is correct. Thank you. And this is because, we'll talk more about this, but when we look at RPRs, and especially for somebody who has a history, well, let me back that up. Anyone for a history of syphilis, the only way to tell if they've been reinfected is by following their serology, unless they have symptoms of primary or secondary disease. And so if we're following this person's serology and we don't have any other history on them, just based on the serology, which their RPR goes from 1 to 8 to 1 to 64, that's considered concerning for reinfection. Anything that's above a 4-fold increase, so you can just imagine multiplying that 8 times 4, is considered concerning for reinfection. And A also had an increase in their RPR, which may be concerning, but that didn't meet the criteria for 4-fold increase or greater, and that's only a 2-fold increase. So if that person went from 1 to 1 to 1 to 4 or 1 to 8, then we'd be a little bit more concerned. And then for patient B, although they have a reactive EIA, their TPPA and RPR were both non-reactive. And if we look at the reverse screening algorithm, which I'll go over with you in just a minute, that likely means the EIA was a false positive. And it's more reassuring that they have confirmation that it's a false positive later on too. Of course, if you were at all concerned for any of these patients, you could retest them. You could also, if they had been exposed or they know they've been exposed, you can also treat them. But just based on serology, C would be the answer. And so I want to talk a little bit more about serology with you. There are methods of directly testing for syphilis from a lesion. That's with PCR as well as dark field microscopy. Unfortunately, those are not widely available. And so we rely on serology for diagnosis as well as determining the success of treatment and reinfection. And the serology tests can be broken down into two types. There are non-treponemal tests, which you can see in the blue, and then treponemal tests, which you can see in the red. Non-treponemal tests include RPR and VDRL, and they are quantitative tests that allow for the assessment of disease burden, treatment adequacy, and reinfection. But they aren't specific, so they actually test for antibodies that aren't specific to T. pallidum. They test for kind of a large range of different antibodies. For that reason, they can be positive for patients who don't have syphilis. And that's why we actually require both positive non-treponemal tests and positive treponemal tests to have a diagnosis. And then we have treponemal tests, which include TPPA, TPHA, FTA antibodies, EIA, and CIA. And these detect antibodies that are specific to T. pallidum. Antibodies usually stay positive for life after the initial infection, and they're not quantitative. So for these two reasons, they cannot be used to reassess for reinfection and or response to treatment. Again, you need both a treponemal test that is reactive as well as a non-treponemal test, which is reactive for diagnosis of syphilis. And we'll go through the two ways we can diagnose syphilis. These are the two screening algorithms. One's the traditional algorithm, and then we have the reverse screening algorithm. Starting with the traditional algorithm, which is on the left, this starts with a non-treponemal test, VDRL or RPR. If that non-treponemal test is negative, then the screening is done. They're unlikely to have syphilis. But if it is positive, you need to go on to have a confirmatory test. Again, that confirmatory test needs to be a treponemal test. In this case, we have a TPPA. It could be any of these tests. And if that is positive, so you have a positive non-treponemal and a positive treponemal test, then the person has a history of past or current syphilis, and you would need to figure out if it's past or current and treat them accordingly. And then if the TPPA or the confirmatory treponemal test is non-reactive, then the RPR is likely a false positive, and you can consider them less likely to have syphilis. Moving on to the reverse screening algorithm. This screening algorithm starts with an EIA or a CIA, and then if that is negative, it's automatically or if that's non-reactive, the person is unlikely to have syphilis. But if it's reactive, you have to move on to do a non-treponemal test, an RPR or a VDRL. Again, you need both for diagnosis of syphilis. If that is reactive, you have both, and you can diagnose a past or current infection. But if it is non-reactive, then you're in this awkward situation having a positive and a negative, and you need a tiebreaker. And so you do another treponemal test. In this case, it's a TPPA, but you can use any of them. If it's reactive, then you've broken the tie. You have a treponemal test and you have two treponemal tests that are positive, and this person likely has either a history of syphilis that has been treated, or a history of syphilis that hasn't been treated, and their RPR has decreased to 0 or non-reactive in that time. What you do with that really depends on the history that you gather. If it is non-reactive, then you have two non-reactive tests and a reactive test. That means the EIA was likely a false positive, which we saw for our pregnant patient in that last scenario. Again, I want to talk a little bit more about what you do with the two reactive treponemal tests. So if you have a reactive initial test, a non-reactive RPR, and then a reactive treponemal test again, that indicates likely two scenarios. One is it's a history of syphilis that has been treated. You should ask the patient if they've been treated for syphilis before. If they have been treated before and they're not vulnerable to reinfection, then you don't need to treat them again. It's likely that they've been treated and they just have these positive antibodies for life. But it's really important to assess for vulnerability to reinfection. If they have those two positives, and they've never been tested or they've never been treated for syphilis, then it's likely that they have latent syphilis. Over the time course of a syphilis infection, the RPR or VVRL will naturally decrease to non-reactive, if it just happens. And so you can have two positive tests and a non-reactive RPR, but the person still has a syphilis infection. And so in that case, you should treat them for latent infection. I want to talk a little bit more about what these non-trypanemal tests are, RPR and VDRL, and how to interpret them, especially for a patient who has a history of syphilis. So if you have a patient who's coming in new to you and they've never had syphilis, then a positive RPR is concerning. And as long as you have the positive trypanemal test, you can diagnose syphilis. But in somebody who has a history of syphilis, your trypanemal test will likely always be positive. So you really need to know how to interpret RPR as well. So you can determine if somebody's serology is concerning for reinfection. And so these serologies are really just, they really just correspond to the levels of antibodies in somebody's serum. They're usually higher immediately after an acute infection, and they decrease with time. And so if you see higher antibodies, say like 1 to 1,240, it's more likely they were infected more recently. And then when we look at the change in these serologies, so if you're following somebody who has a history of syphilis, sometimes they are so fast and they kind of just hang out at 1-to-1 or 1-to-2. And if you see them again, you will get an RPR. And if you see a twofold change, so it goes from 1-to-1, say to 1-to-2, that isn't necessarily concerning. This is actually within the margin of error for the lab. It really depends on who's reading it, what lab it goes to. And so we don't consider that concerning. Of course, if they have a history or they have a chancre or some other thing that indicates they have primary or secondary syphilis, treat them. But this alone, a twofold increase alone is not concerning. And then a fourfold change is concerning. And fourfold changes should be sustained for 2 weeks to be significant. Sometimes you can see slight fluxes in RPRs, and they're a very imperfect test. But a sustained fourfold increase for more than 2 weeks is considered significant. And for somebody who has a history of syphilis, especially if they're vulnerable to reinfection, say if they went from 1-to-4 to 1-to-16, that would be enough to consider them to have a reinfection if they are vulnerable. If they're not vulnerable to reinfection, say they go from 1-to-1 to 1-to-4, they aren't having sex at all, they haven't had sex since you last tested them, you could repeat that in 2 weeks. And if it's sustained, maybe treat them or maybe get a better history, see what's going on. But if it's not, sometimes they'll just go down on its own, and that was just kind of a blip. And then when you're ordering serologies, it's really important to order the same serology that you ordered in the past. So if you are getting RPRs on somebody, make sure you continue to get RPRs. If you're getting VDRLs, continue to get VDRLs. These are not comparable, unfortunately. RPRs tend to be higher than VDRLs. So bringing us back to the case, you might remember we had a 19-year-old who newly found out she was pregnant before she was at 18 weeks and 6 days, and she was referred to OBGYN. Unfortunately, she missed her initial appointment, and she followed up with her OBGYN at 33 weeks gestation, and she's complaining of a few mildly painful genital sores at that time. Her partner was recently released from jail, and you do an exam, and this is what you see. I'll describe this for you. There are 3 ulcerative lesions with what appear to be raised borders, and it's hard to provide much more of an exam without being able to actually physically examine them. But you can imagine they might be indurated. And so based on this, both the physical exam as well as the history, mildly painful genital sores, what diagnosis do you think is most likely? Any brave souls? You might be able to guess just based on the name of the presentation, but great. I heard primary syphilis. Yes, this is primary syphilis. This could be very easily confused with genital herpes. We commonly think of genital herpes as having multiple lesions, as well as being painful, but usually very painful. And genital herpes usually starts as a vesicular rash, and then those vesicles erode into ulcers. And so it's very easy to confuse genital herpes with syphilis. Primary syphilis, as we'll learn, usually presents as a chancre, which is typically a single ulcerative lesion with a clean base, round, rubbery, raised borders. But atypically, it can present with multiple lesions, and it can also be mildly painful. So if you're seeing somebody with an ulcerative rash, and you're thinking genital herpes, you should also be thinking primary syphilis and be testing them for syphilis. We'll learn more about secondary syphilis and the symptoms associated with that. And then chancroid is another ulcerative infection caused by Haemophilus ducreyi, and it usually causes extremely painful ulcers and painful lymphadenopathy. So this is not consistent with that. And we've just learned this patient probably has early syphilis, primary syphilis in pregnancy. And so I want to talk a little bit more about early syphilis with you. And as I mentioned, we'll be coming back to this natural history slide multiple times, but this time I just want to talk about primary syphilis. So starting on the left, we have an exposure. 30 to 50% of those people who are exposed will go on to develop an infection and primary syphilis. And again, that incubation period is usually 3 to 4 weeks, but it can be anywhere from 10 days to 90 days. So it can be quite variable. And just it's important to keep that in mind. And when you're taking a history, somebody might not think of an exposure that was 90 days ago. So it's really important to kind of probe for that. Once somebody develops a chancre, the primary syphilis is defined by a chancre, which is a single, painless, indurated, clean-based lesion with raised, rolled, rubbery edges. And again, this can be this is the typical chancre. They can present atypically with multiple lesions or mildly painful lesions. These can very often go unrecognized just because they're in areas which we aren't able to usually see ourselves, and they are usually painless. So it's very easy for people to not even know they have these. And they can also have some associated lymphadenopathy and regional lymphadenopathy, which is different than secondary syphilis, where it's a more generalized lymphadenopathy. These are multiple examples of chancres. You can see at the top left and right, as well as the middle bottom. These are the more typical presentation of a chancre, with the ulcerative lesion, a clean base, kind of raised, rounded, rubbery edges, or you can imagine they feel rubbery. And then we have this. I like this because we also have two atypical appearances. You can see the perianal rash, which has multiple ulcerative lesions that could be very easily mistaken for genital herpes or anal genital herpes. And then we have the rash on the shaft of the penis at the bottom right, in which we have multiple ulcerative lesions as well. And that could also be very easily confused with genital herpes. Chancres can happen at any site of inoculation. It doesn't only have to be the genitals. And so here we have a few examples of that. We have two facial labial chancres, and then we have a chancre on the tongue, and this is another chancre on the digit. They can really be at any site of inoculation, though. And so, as we've learned, primary syphilis can be very easily mistaken for other things, and this provider maybe thought that given the patient's history of herpes or HSV, this was just another HSV outbreak, and they prescribed this patient acyclovir, and recommended a cyclovir suppressive therapy from 36 weeks to delivery for suppression. They got prenatal labs. Remember, this patient didn't have any first trimester prenatal labs, so they added all those labs on, including a CBC, GLT, type, and RH, urine, UA and urine culture, quantiferon, rubella, Hep C, Hep B, HIV, RPR, and urine gonorrhea, chlamydia. And the patient was given a lab slip. They were told to follow up. Unfortunately, they weren't able to follow up, and so they weren't able to get their labs. But the patient did represent to the emergency department at 37 weeks gestation. And at that time, she was complaining of a non-puritic full body rash. She had no history of travel, outdoor activities, new detergents, or self-care products. And she works in housekeeping in a hotel, and she has a dog, but hasn't noticed any fleas on the dog. And you do an exam, and or the provider does an exam in the ED, and this is what the provider sees. In addition to the full body rash, they also see a rash involving the palms of the hands and soles of the feet, which I would describe as a numerous hyperpigmented macules. And so based on this, what do you think the most likely diagnosis is? Possible answers include eczema, scabies, contact dermatitis, primary syphilis, or secondary syphilis. Yes, secondary syphilis. This might sound repetitive, but I really want to. We see patients have these rashes all the time and get missed, so I just want to reinforce that for you. This is secondary syphilis. Again, characterized. Well, actually, we'll learn about secondary syphilis in a second. But the rash is usually a full body rash, and it characteristically involves the palms of the hands and the soles of the feet, and it's usually not itchy. She has a history of eczema, but again, eczema is usually extremely itchy and more localized. She does work in the hotel industry, and maybe she had an exposure for scabies or possible exposure for scabies, but that's usually described by intradermal rash or itching, and you can usually see the lines associated with the arthropod, as well as a kind of punctate lesion at the site. And then, so less consistent, also less consistent with contact dermatitis, which is usually more localized and associated with an exposure. And then we already learned about primary syphilis. Okay, and then back to the case. This provider unfortunately suspects fleas versus scabies. Again, we see this mistake all the time, so I just want to draw your attention to something that really does happen all the time. And they instructed the patient to check their home and pets for fleas, and they prescribed permethrin cream as well as hydrocortisone. And they are instructed to follow up with their primary care doctor and their prenatal provider, and they don't do any labs while in the emergency department. And the rash resolved 2 weeks later, and she didn't have any time to follow up, so we could just do the work. And so we've diagnosed this patient with secondary syphilis, or what appears to be secondary syphilis. So I want to bring you back to this natural history and go through what all of the signs and symptoms of secondary syphilis are. Again, you might remember this patient has been exposed. We've seen them have primary syphilis, and usually 2 to 6 weeks after somebody presents with their chancre, they can go on to develop symptoms of secondary syphilis. Most commonly, that includes a full body rash, which often involves the palms and the soles, as we saw in this patient. They can also have generalized lymphadenopathy and constitutional symptoms such as headaches, malaise, fever, or mild fevers, body aches. They can also have mucus patches, condylosa malata, and patchy alopecia. I'm going to review what all those things are in just a moment. And at any point, remember, at any point during this process, somebody can develop this neurosyphilis. So these are examples of secondary syphilis rash, or the typical secondary syphilis rash. And those with, again, it's usually a full body rash that characteristically involves the palms and the soles. And in those with darker pigmentation, sometimes these macules can be mistaken for scarring. So it's really important to have a good understanding of what this can look like in all skin variation. And as you can see, it's best demonstrated on the scrotum rash as well as the rash to the very left. these macules can have an overlying kind of scale to them or dryness, but often it's not itchy. And then that photo is another example of a palm and sole rash. These are mucus patches. They're raised white plaques in the mouth, and they can present on any surface in the mouth. And you can't scrape them off. But these can be very easily confused with a few other things that cause raised white plaques in the mouth. Here we have an example of thrush, which is a candidal infection. It usually happens during immunosuppression. And notably for thrush, it can be scraped off. So if you use like a tongue blade or something, that can be moved. Then we have another example of a raised white plaque on the right, which is oral hairy leukoplakia. This is caused by Epstein-Barr virus, usually in the setting of a severe immunosuppression. And it can be very difficult to tell the difference between this and mucus patches associated with syphilis. Notably, a characteristic of oral hairy leukoplakia is there are some vertical lines in it. You can kind of see that in this one, the vertical lines in the patterning of the patch. And it's not scrapable, but it usually does present on the sides of the tongue and not other surfaces. Here's an example of patchy alopecia. This can be confused with alopecia areata. So if you're seeing somebody with patchy alopecia or hair loss, it is important to keep the rod differential. This can also involve the eyebrows. And here are examples of condyloma lata. These are usually multiple raised whitish gray lesions, and they're usually found in warm, moist areas on the body, which are the perianal, the perineal, and perivulvar areas. And they're very infectious, and they can also be quite painful just because of the moisture and the maceration that can kind of occur with them. These can be very easily confused with anogenital warts or HPV. I want to show you what HPV usually or can look like. Usually with HPV, rather than those kind of single raised sessile lesions, we have more cauliflower-like lesions. And so that's one way to tell the difference. Of course, if you are concerned, if somebody has a new HPV infection or new occurrence of anogenital warts, it's always important to think possibly syphilis. And so we had this patient who came into the emergency department. They were unfortunately misdiagnosed. And this is something that happens quite often, and we recognize this. We also recognize that often patients who need prenatal care can only get that care through the emergency department, or they're only seeking care through the emergency department. And so this is often a site, and sometimes the sole site, where a person might be seen during their pregnancy. And for that reason, CDPH added screening during ED visits to their recommendations during the expanded screening or syphilis screening recommendations. As you can see, number 2 on here, which is in the orange, emergency department providers and local health jurisdictions with high CS morbidity should consider confirming syphilis status of all pregnant patients, prior to discharge. And you might remember that map with all the orange local health jurisdictions that I showed earlier. 2/3 of local health jurisdictions are considered high risk or have high CS morbidity. So it's more likely than not that you're living in one of those jurisdictions. And there's quite a bit of data that helps support this practice. These came from interviews that were done on birthing parents who were affected by congenital syphilis. There were 1,204 patients interviewed, and looking at where they sought care during their pregnancy. As you can see, 24 of them sought care in the emergency department, 16% sought care at social supportive services, which included places like WIC, and then another 5% got care while in correctional facilities. Unfortunately, although there was a very high rate of patients seeking care in emergency departments, 28% of those did not get tested for syphilis during their stays in the ED. And then for those who were tested and tested positive, only 59% of those did not actually initiate treatment. So it was a missed opportunity as far as starting treatment for them. And with kind of recognition that the ED would be a really great place to kind of catch some of these cases of syphilis during pregnancy and help mitigate primary syphilis. CDPH has made recommendations to emergency departments to consider opt-out testing for multiple different infections, including syphilis. So syphilis, HIV, and Hep C. Again, this is supported by California state law, and here is just the Dear Colleague letter that was released in May of 2022 that essentially says that. If this patient was recognized to have primary, secondary, or early latent syphilis during any of her visits, she could have been treated. The treatment for early syphilis during pregnancy is the same as for syphilis when somebody is not pregnant. And that is a single dose of benzathine penicillin G or BPG or bicillin LA, 2.4 million units IM as a single dose. Some experts may recommend a second dose. There's no like firm recommendation about that, but if you read the CDC's website, you might see that. And then remember that pregnant people can only be treated with penicillin. And so if they have an allergy to penicillin, they should be desensitized and then treated. Unfortunately, medications that we use for persons who are not pregnant, including doxycycline, are contraindicated in pregnancy due to being category D. And then ceftriaxone, although it can be used outside of pregnancy, there's no studies that have been demonstrated during pregnancy, and so we would not recommend using that. And so let's say we treated this patient and we got the RPR and we wanted to follow them. As with any other patient who was not pregnant, it's really important to follow serology so you can see the adequacy of treatment and whether or not you were successful. As I mentioned before, a fourfold increase is concerning for reinfection. We also look at for a fourfold decrease to determine treatment success. This is in a pregnant as well as a non-pregnant patient. And this can take anywhere from 6 to 12 months, depending, well, 6 months to really 2 years, but depending on the stage of infection. But you should be following that patient fairly closely. For somebody who is pregnant, you shouldn't get an RPR sooner than 8 weeks after their initial treatment. You can actually see an increase in RPR before you see a decrease. So that would be something concerning to see, and it might trigger you to try to retreat when you actually don't need to. And then all persons who are tested or who have syphilis during pregnancy should have an RPR drawn at delivery. And it's regardless of timing. So say you had an RPR from a month ago and it hasn't been 8 weeks, but they're delivering now, you should get that RPR. That's not necessarily to determine treatment adequacy for the parent, but it's actually to compare to the infant's RPR. It's important to have both of those. And then it's all important to remember, we might not see that fourfold decrease before somebody delivers, and that's okay. But it's just something to remember. Because we won't actually see that fourfold decrease, we have other ways of determining adequacy of treatment during pregnancy. And those are listed here. Treatment needs to have occurred 30 or more days prior to delivery to be considered adequate. You also need to have no concern for reinfection, so no new exposures, and have no sustained fourfold increase in the maternal RPR. Again, because we might not reach that fourfold decrease prior to delivery, these are things you can use to determine treatment adequacy prior to delivery. So now remember, we have a pregnant patient last seen in the emergency department at 37 weeks. She is representing in labor, so labor and delivery at 39 weeks gestational age. She's been taking her acyclovir suppressive therapy, and on exam, she has no perineal lesions that are concerning. She goes on to have a spontaneous normal vaginal delivery without any complications. The APGAR scores of the infant are 8 and 9, and the neonatal exam just shows a normal appearing female infant. And the hearing screen was deferred to the first pediatric visit. And the family was discharged 2 days later to follow up with the PCP and the pediatrician. And I hope we got all of us get this correct. But this is really just to solidify that with you for you, and that is who should be screened for syphilis at delivery. Great, love it. Again, all persons except those who are low risk and have a documented negative screen should be screened at delivery. And we've already gone through the factors that may make somebody more vulnerable to infection during pregnancy via kind of a graph form, but I want to show that to you in this list form. I often find referring to a list is very helpful. And I don't want to go through all of these with you, but I do want to draw your attention to the risk factors that our patient possesses. And that includes late presentation to prenatal care. Remember, she presented around 19 weeks gestation. Additionally, although we don't know where she is currently living, it's very possible she lives in one of the many LHJs in California that are considered to have high morbidity for syphilis among females, as well as congenital syphilis. She does have a sex partner who was recently incarcerated, and she does have a history of another STI, specifically genital herpes or HSV, within the last 12 months. And remember, they were sent home, healthy baby, but mom brings the baby back to the pediatric emergency department about 2 weeks later, when the baby's 2 weeks old, due to fussiness and decreased movement in the right arm and left leg for about 2 days. The mother isn't sure what happened. She denies any trauma, falls, or other mechanisms of injury. And the baby has felt warm, but there haven't been any measured fevers. And mom gave Tylenol once, but it didn't seem to help much. You get a set of, or the provider gets a set of vitals, which are normal, and they also do a thorough physical exam, which shows a crying infant who is consolable. ENT exam shows mucous membranes that are moist and fontanelles that are flat. The pulmonary, cardiac, and abdomen exam, as well as the skin exam at the bottom, are all unremarkable. And then notably, the neuro exam shows a right arm that is laying flat at the side with a slight internal rotation. And the extremity exam shows no spontaneous movement of the right upper or left lower extremity with increased crying with any passive range of motion of those joints. The provider gets an x-ray, and the preliminary read is periosteitis of the diaphysis of the left femur, which you can see here, as well as the right tibia, as well as a possible fracture of the the right ulnar metaphysis, which you can see here. So based on the x-ray and the history and the physical that you've gathered, what do you think the most likely diagnosis is? Yes, I'm context clues, yes. Congenital syphilis. But I do want to draw your attention to these other things. Given the preliminary read with that possible fracture of the ulna, it might be very easy for a provider to draw conclusions about non-accidental trauma or abuse. I just want to say that a lot of patients or a lot of families who are affected by congenital syphilis also have a long history of trauma associated with healthcare systems, and drawing conclusions prior to actually having information or thorough information is not good and re-traumatizing for a lot of families. And it can further exacerbate the entire situation. So I really want you to keep a very broad differential when seeing patients like this in the ED to not further cause trauma. B, birth trauma not identified at delivery. This patient didn't have any physical exam findings that were concerning after delivery, and they did not have a vacuum assisted delivery or other device assisted delivery, so it's unlikely. And then congenital syphilis or congenital CMV can present with hepatosplenomegaly and skin findings similar to congenital syphilis, but it usually doesn't present with bone findings, so that's why it's less likely. Okay, we're going to take a short break, after which we will continue.
So, as Wyatt explained, we're going to continue with our case, and we just made the diagnosis of congenital syphilis on this patient, or this infant, I should say. So what you need to know about congenital syphilis is that it can occur at any gestational age, and it can occur with any stage of syphilis. So primary, secondary, late, unknown duration, any of those, you can have perinatal transmission. If the infection goes untreated in the mom, 80% of infants will then acquire congenital syphilis. And amongst those infants that acquire congenital syphilis, up to 40% of those will be stillborn or die in early infant death. So really important to keep congenital syphilis high on your differential diagnosis. So just going through some of the potential findings that you could see in an infant born with congenital syphilis. During their gestation, they can have preterm, they can have hydrops fetalis, they can have intrauterine growth retardation, or they can be small for gestational age. They can have fever and irritability, much like our patient did. They can have a rash, nasal secretions that tend to be copious and are called snuffles. They can have mucus patches, much like you saw in the adult. You can see similar mucus patches in infants, and they can have adenopathy. Neurologically speaking, they can have abnormal reflexes or abnormal motor development, and they can fail their hearing exams because one of the most early signs of particularly neurologic involvement with syphilis is decreased hearing. For musculoskeletal, they can have osteochondritis, periostitis, and pseudoparalysis. So much like our infant who had involvement of the bone below, they'll get a pseudoparalysis because of the pain that they have in the bone when they try to move it. They can have a pneumonia alba, and very important, this is not the pneumonia alba you've been hearing about that's been all over China recently. This is pneumonia alba from congenital syphilis, and it occurs in the infant early between 0 days and 2 years of life. They can have a myocarditis, and syphilis can really involve any part of the heart, but we'll often see myocarditis in infants. From a GI standpoint, they can have pancreatitis, GI malabsorption, hepatosplenomegaly. Remember, our infant had hepatosplenomegaly. They can have anemia, thrombocytopenia, which are low platelets. They can have a low glucose. They can have an elevated AST and ALT, which are liver transaminases. They can have an elevated direct bilirubin. And when you do a lumbar puncture, they can have an increase in their WBCs, an elevated protein, and a reactive VDRL. So let's go back to our case. Unfortunately, for this infant, it was suspected that this infant had non-accidental trauma. The baby was placed in a sling and hospitalized on a CPS hold. The CPS and police department interviewed the mother. The mother, as you can imagine, was very tearful, very frustrated because she didn't know what had happened. And she didn't remember the infant falling or anything. And she had never left the infant out of her sight with somebody else. So mom, as you can imagine, is very traumatized by this experience. When labs are done, the white count is 12.5. The infant is anemic at 8.5, elevated AST and ALT at 63 and 105. An elevated ESR, which, as you know, is often not helpful because it means something's going on, but you don't really know what. Similarly, with an elevated C-reactive protein. On imaging, though, the CT of the abdomen showed hepatosplenomegaly. The MRI of the upper extremities showed a subperiosteal abscess and a right ulnar osteomyelitis. The infant was placed on vancomycin and ceftriaxone, and CPS hold continued. The parents could receive information, but they could not visit their infant. So what workup would you recommend at this time for the infant? What further workup? Yeah, agreed. D. Certainly you could do A, you could follow up the CBC, you could do blood and urine cultures, and probably this infant got all of those. Stool studies, probably, unless you saw diarrhea, wouldn't really be realistic. Maybe if you did a full workup and found nothing, you might end up doing genetic testing. But most important here is an HIV test, an RPR, a lumbar puncture with a VDRL, and looking for white count and protein, or elevated white count and elevated proteins. Oops. Okay, good. So when you're evaluating an infant that may have been born to a mother who might have syphilis, in this case, maybe they didn't know at the time, but when you are looking to see if an infant has syphilis, you look for both infant criteria and maternal criteria. And the infant criteria is that the infant has findings on exam that are consistent with congenital syphilis. Does that fit our infant here? Absolutely. We have an osteomyelitis. We also have a low hemoglobin. I guess those aren't physical exam findings, but they're lab findings. We have an elevated AST and ALT, or elevated liver transaminases. So our infant has physical findings consistent with congenital syphilis. They could be from other things, but they can also be from congenital syphilis. So we would say our infant meets infant criteria. Other ways that the infant can meet infant criteria, and Wyatt went over this with you, if the infant's RPR is 4 times or greater or 4-fold higher than the maternal RPR, if you are able to get a placental or lesion swab and you identify either through dark field microscopy or through PCR testing that that's syphilis, then those would also meet infant criteria. Unfortunately, most of the time, the only time that you will actually get a placental testing is when the infant is a stillborn. In any of these cases, if the infant meets infant criteria, then the infant needs to go through a full evaluation. And that includes lab work, the CBC that we already have, a lumbar puncture looking for VDRL, white count, protein, and also long bone x-rays. In our case, our infant already had an MRI and had those long bone x-rays as well. If any of this is positive, the infant then is committed to 10 to 14 days of IV aqueous crystalline penicillin. So again, just to reiterate this, what is a 4-fold increase from mom to infant? Basically, it's 4 times whatever mom is, right? So if mom's 1 to 8, 4 times that is 1 to 32. So just do those multiplications. If it was not a full 4-fold increase, although congenital syphilis is less likely, it is not completely ruled out. So 2 times or 2-fold would be, again, less likely, but not completely ruled out. So the infectious disease doc consulted recommended an HIV test, a respiratory viral panel, an RPR, and a hearing test. The HIV antibody test was done, it was negative. The respiratory viral panel was negative. The RPR was 1 to 1,024. That's extremely high for an infant. And then the infant here failed bilateral hearing test. And remember what I said previously, hearing is one of the first things we see go in neurosyphilis. So always asking about decreased hearing if you're looking at an adult, if you're examining an infant, doing a hearing test. So based on the RPR finding, the ID doc recommended an RPR. The VDRL on the, or I'm sorry, not an RPR, a lumbar puncture. The VDRL on that was 1 to 4. There were 9 white cells and a very high protein at 366, and just a few RBCs, 4 RBCs. The RBC piece is really important because if you had thousands of RBCs, 10,000, 50,000 RBCs, then that elevated protein could be secondary to those RBCs. And so it's important to know what those RBC counts are when you see an elevated protein. So again, this infant met infant criteria based on clinical findings alone, then met infant criteria based on the lumbar puncture with the elevated white count, positive VDRL, and elevated protein. So this infant is committed to aqueous crystalline penicillin G, 200 to 300,000 units per kilogram by body weight, IV, administered 50,000 units per kilogram body weight every 4 to 6 hours for 10 days. And now that non-accidental trauma concern is resolved. But imagine this is, a few days later, mom has been traumatized for the rest of her life, really, because she was taken away from her infant, as has the infant. So just reiterating, we're here on this algorithm for determining whether or not your infant has congenital syphilis. And we're talking about infant criteria. Again, there's also maternal criteria, which we'll talk about a little bit later. And I already reviewed the treatment, which is crystalline or aqueous crystalline penicillin. You want to pay attention to what the treatments are. That's the IV version of penicillin. So when do you follow up the infant? When you've treated them for congenital syphilis or probable congenital syphilis, you want to check an RPR every 2 to 3 months, but realize that you may not see that RPR begin to decline until you're about 3 months in. So if you get one at 2 months, it may still be the same, so don't be surprised. You look for an infant who has persistent titers with a fourfold, you're looking for either an infant who either does not have a fourfold decline at 6 to 12 months or who has persistent titers. And so that infant, you have concern that maybe you have not adequately treated that infant. That infant needs a follow-up lumbar puncture and potentially repeat treatment. Also, if you have an infant that begins to show syphilis clinical findings again, then you would also want to repeat an RPR, even if it's not when you were planning to do that follow-up RPR. And based on the finding of that RPR, may also need to do a lumbar puncture and consider repeat treatment for that infant. So again, if you do not see a fourfold or greater decline by 6 to 12 months, that's when you're thinking you may need that repeat lumbar puncture. So this is our infant. They in the hospital had a 1 to 1,024. 4 months later had a 1 to 32. At 6 months had a 1 to 32 again, and at 9 months had a 1 to 8. They're gaining weight. They're meeting developmental milestones, but they have failed their bilateral hearing test. And my question for you is, does this infant need a repeat lumbar puncture at this time? Yeah, well, if you take 1,024 and divide it by 4, you get 256. So that RPR needs to be below 1 to 256. We're well below that at 1 to 8. Why did the infant fail their bilateral hearing test, though? Yeah, so when the hearing is lost in someone who has neurosyphilis, you often do not recover that hearing, or you recover a little, but not most of that hearing. And so that hearing loss is potentially long-term for this infant. So you're not surprised that they're still failing their hearing test, but you are having good serologic response, and you're also seeing an infant who is otherwise thriving. So are there any other tests that you want to do now? Test mom for syphilis, test dad for syphilis, test mom and dad for syphilis, or test mom and dad for HIV and syphilis? D, yeah, absolutely. Remember, when syphilis is transmitted, first of all, there's an increased risk of acquiring HIV within the next year, but also often syphilis and HIV can be co-transmitted. So unfortunately, the mom left the hospital because remember, she's picking up her infant from the NICU at this point, and no one had scheduled her for a follow-up visit so that mom could be tested and treated. She shows up to the emergency department 18 months later. She's complaining of lower abdominal pain and some vaginal bleeding or spotting. On exam, you identify an 18-week intrauterine pregnancy. Her urine pregnancy test is positive, and you perform the baseline prenatal labs. Her social history, unfortunately, now she's actively using methamphetamines. The patient is referred to the OBGYN for follow-up prenatal care. And, you know, the patient never shows because look what just happened to her. She's traumatized by the experience that she's had, so she doesn't show back up for prenatal care. The labs return after she's discharged from the hospital. Her TPA is positive, her RPR is 1 to 16, and all other tests are negative. The emergency department refers the patient to the public health department. And my question for you is, what is her diagnosis now? She has syphilis, right? Where is she? What stage of syphilis is she in? Primary, secondary? Yep, late or unknown duration syphilis. So she's, as Wyatt had shared with you, she's already gone through her primary atypical ulcerations with multiple ulcerations that were slightly painful, often confused for herpes. She came in then later, recovered from that, fine, came in later then with her secondary syphilis, which was a diffuse body rash, including the palms and soles. Again, often missed because providers look at it and they just don't recognize it because they haven't seen it before, and it can really often look like scarring, particularly on hyperpigmented individuals. So this mom is now in late latent. She's been infected for over a year, so that puts her into late latent. And she falls here. So the treatment then, just to reiterate the treatment for primary syphilis, it's benzathine penicillin G. So again, not the crystalline penicillin that we were talking about for IV for the infant, but this is benzathine penicillin G, also called bicillin. When you hear the term bicillin, we're talking about that IM injection, 2.4 million units IM, a single dose if they have primary, secondary syphilis, or it's been less than a year since they were infected. If it's been a year or for unknown duration, you don't know how long it's been, then that treatment is the same treatment, but it's 3 doses given 7 days apart. So 1 dose a week for 3 weeks. So the public health disease investigator is a public health nurse. They find the patient now living under a bridge. The public health nurse goes there and delivers treatment right in the field. And I can tell you that this field delivery is going to be critical to us getting the syphilis epidemic under control. Her first dose is on April 1. The second dose is on April 7th. Unfortunately, when the public health nurse goes to find her for the third dose, they cannot find her. And they finally find her on April 19th and give her her third dose. Recall we said dosing needs to be every 7 days, roughly. And so if the infant, or if there's more than 7 days, or in the case of, you're looking to dose every 6 to 8 days in California. So if the dosing occurred for greater than what we say is 9 days in California, then you need to go back and restart treatment. And unfortunately, this infant shows up to the emergency department at 37 weeks gestational age. She's in active labor, and she has a normal spontaneous vaginal delivery of a healthy infant male, APGARs 8 and 9. So does this infant meet criteria for congenital syphilis? Well, there's 3 questions you need to ask yourself. Was mom treated? Was she? Yeah. Was she treated adequately? No, right? Because she had too long of a stretch between her second and third dose. She had 12 days between her second and third dose. In California, we recommend 6 to 8 days. If you hit 9 days or more, you need to restart that full 3 courses or 3 doses of treatment. The CDC will stretch that out to 9 days, but we have some preliminary data in California that says if you go out to 9 days, you're going to have an increased risk of congenital syphilis. So here in California, we say that each of those doses need to be 6 to 8 days apart from each other. Was she treated on time? No. Well, was she? She presented at 18 weeks to the emergency department, and then she delivered at 37 weeks. So was she treated on time, even though she was inadequately treated? So yeah, I guess it's a little bit of a tricky question, because if she was adequately treated, then she would have been treated on time because she was treated more than 30 days prior to her delivery, or her initiation of treatment needed to be more than 30 days prior to treatment. Because she was inadequately treated, although she did initiate her treatment prior to 30 days from her delivery, she would be considered inadequately treated and not treated on time because you never completed the treatment. So a little bit of a tricky question on this one. So this is really what I've been saying. The injections must be given every 6 to 8 days. And if they're at 9 or greater days, then you need to start over. And again, the CDC allows up to 9 days, but based on California data, we see some increases in congenital syphilis when we hit 9 days. So we're sticking with 6 to 8 days in California. So once you stretch beyond that, you need to restart all 3 of those doses. So looking at, does this infant need a further workup, and what criteria does this infant meet? So this infant would fall into maternal criteria. Again, the questions were, was she treated? She was, right? Was she adequately treated? No, she was inadequately treated. So she would meet the second criteria here under maternal criteria. She could also have been treated someplace else, and you cannot find documentation of that treatment. If you can't find documentation, then you have to assume that this infant meets maternal criteria. Finally, she could have been treated with the wrong benzathine penicillin G. Some people will sometimes use 1.2 milliunits when they really need the 2.4. So if she got the wrong dose, even on one of those 3 doses, she would be inadequately treated. So then this infant needs a full workup. They need the labs, the CBC, chemistry panel, they need a lumbar puncture, and they need long bone x-rays. And then if any of those are abnormal, then this infant needs the aqueous penicillin G. A little loud out there. If they're all totally normal and you can confirm that the mom will follow up with that infant, you could get away with a single IM dose of benzathine penicillin G. So again, if anything's abnormal or you don't think that mom's going to follow up, then you are committed to a 10 days of IV crystalline. If it's all of those labs are normal and you think mom is a good follow-up, then you can get away with a single dose of IM benzathine penicillin G. So this infant had their lumbar puncture. Their labs were an RPR of 1 to 8. For their CSF, they had 10 WBCs with a lymphocyte predominance, which is what is more consistent with syphilis. And they had a slightly elevated protein at 120, nothing like our previous infant. And although not documented here, the RBCs were 1. So again, this infant gets aqueous crystalline penicillin G, and that's given IV for 10 days. Alternatively, occasionally used is IM dosing of procaine penicillin. That's for IM dosing, and that is 10 days outpatient, but you would have to feel really confident that that mom was going to bring that infant back for all 10 of those days for that IM dosing. And then, like we said, if you had done that workup and that workup was completely negative and mom was going to bring that baby back, then you can get away with that single dose of benzathine penicillin G, also called bicillin. So these are the infants' follow-up RPR after their 10 days of IV treatment. And their RPR is 1 to 2, and their 6-month RPR is non-reactive. The infant continues to do well, meeting their developmental milestones. They're gaining weight normally, and they pass their hearing screens. Does this infant need a follow-up lumbar puncture? No, definitely not, because you're already non-reactive at 6 months. So you've fully resolved your RPR by 6 months. Okay, so let's go back to mom. So mother left the hospital against medical advice after infant number 2 was born. You can imagine why, right? That was a horrifying experience that she went through previously. She wants to get out of there. 6 months later, she shows up to your clinic. She's complaining of an 8 out of 10 headache times 3 days. Also, she has left eye pain and some redness of her eye and photophobia. She has subjective fevers, no nausea, vomiting, and she has no complaints of loss of hearing or vision. 2 really important questions when someone who you think might have syphilis and might have neurosyphilis, or frankly, if they have syphilis at all, is you want to know, are they having any changes in their hearing, and are they having any changes in their vision? She's still using methamphetamines. On exam, you notice just a mild conjunctivitis. However, you call the emergency department and advise them you're sending the patient over, that the patient needs a full workup for neurosyphilis. They need a CBC, a chemistry panel, an RPR, a TPPA, a lumbar puncture, including a VDRL, cell count, and protein, that they should empirically begin this treatment on IV aqueous crystalline penicillin. Where have you heard that before? Right, that aqueous crystalline penicillin, that's the IV treatment that you use for neurosyphilis. And that the individual needs an ophthalmology consult. So the emergency department draws the labs. They give a IM injection of benzathine penicillin G. Was that the right treatment? No, you ask them, look, give them IV crystalline penicillin because I think this patient has neurosyphilis. The ophthalmologist comes in, does a consult, says, this is conjunctivitis. What are you worried about? So the ED doc discharges the patient based on the ophthalmologist's recommendations, and this absolutely happens. This absolutely did happen. And the RPR later comes back 1 to 28 with a TPPA that's reactive. So a theme that you're probably beginning to notice is that individuals present for clinical care, they're often misdiagnosed, and providers are not thinking about syphilis. This is a big issue that we have as we try to combat the syphilis epidemic that we have right now. She then, because she was discharged from the emergency department, she shows back up to your clinic 2 weeks later. She has increased headache, photophobia that is so severe she is lying face down, looking at the floor to avoid the light. And when you walk in the room, she asks you to turn the lights off. She complains of blurry vision. And on exam, you notice a bluish colored pupil and pupils that accommodate but do not react. There's your blue tinged pupil. And this is a rare but possible complication of ocular syphilis. And it can be seen as an individual is progressing towards blindness from their syphilis. Not everybody gets this before they go blind, but you can see it. And then those neurologic symptoms that she has, where she accommodates. So when you bring your finger in, her eyes accommodate and follow your finger. But when you bring a light in from the side, they do not react. They do not constrict. So it accommodates, but it does not react to the light. This is the classic Argyll-Robertson pupil. All of us heard about it in medical school. Most of us have never seen it until more recently, in the last 5 to 10 years. For those of us that are as old as me, that is. Okay, so how do you identify neuroocular or otic syphilis? So neurosyphilis can really present as any neurologic presentation. Some of the common ones: headache, numbness or tingling. They can have cranial nerve dysfunction, and classically the cranial nerves involved with syphilis are cranial nerves 6, 7, and 8. So they can have symptoms associated with that. They can have a new onset weakness, problems walking, difficulty with memory or confusion. They can have personality changes, altered mental status. They can present like this patient did with blatant symptoms of meningitis, and they can also have a syphilitic stroke. For ocular presentation, same thing. It can literally involve any part of the eye. The earliest presentation is just a red eye, a conjunctivitis. So you really have to increase your suspicion in an individual with conjunctivitis. They can have changed or blurry vision. They can have double vision. If you're involving that cranial nerve 6, they can have flashing lights. They can have floaters, pain, this rare complication I showed you, that blue pupil. And if all they have is the if all they have is the ocular symptoms with no neurologic symptoms, you don't need to do a lumbar puncture. You can just commit that patient to 10 to 14 days of IV aqueous penicillin. What about our patient? Did they have neurosymptomatology? Yeah, they did, because they had that Argyll-Robertson pupil, which, although presents on the eye, is actually evidence that it's involving this central nervous system. And then otic, right? You've heard it now from me a few times. One of the earliest, subtlest findings that neurosyphilis is, that individual is progressing towards neurosyphilis is just some loss of hearing. So you really want to ask every patient with syphilis, have they had any decreased hearing in the last month or two? And again, if all you have is that loss of hearing, you can commit that patient to the IV treatment for 10 to 14 days, and you don't have to do a lumbar puncture. If you have any neurologic symptoms, you want to do a lumbar puncture because you need to, or you may need to follow up the lumbar puncture in that individual if they don't recover as expected. And then the findings on lumbar puncture. Again, you've heard this a little bit with the infants, but the VDRL is highly specific, but only about 50% sensitive. So it's not always positive in individuals who actually have neurosyphilis. So we have to look at the other things like the white cell count and the protein. The FTA ABS on the CSF is highly sensitive, but not very specific. So it may turn positive when something else is going on. So we look at the cell count, particularly the white blood cell count. If there's an elevation of the white cell count, it's often the lymphocytes that are elevated. So they have what is called a lymphocyte pleocytosis. And we look for elevated protein. And I'm sorry, I forgot to make this edit last night. The increased lymphocytes should be under the cell count and not under the increased protein. If the CSF is completely normal, the likelihood that that individual has neurosyphilis is almost zero. The only time you might have neurosyphilis with a completely normal CSF is someone who's had neurosyphilis for a long time, and they have Tabes dorsalis. Those individuals can sometimes have burnt out neurosyphilis, and so they can have a normal lumbar puncture. But if you had the clinical findings, you would be suspicious for neurosyphilis, and you would treat them clinically for neurosyphilis. So ocular syphilis, again, can involve any part of the eye. You can have a posterior or pan-uveitis. You can have an anterior uveitis, an optic neuropathy, interstitial keratitis, retinal vasculitis, and this rare bluish pupil presentation. It's often unilateral and it can progress to blindness. And again, neuro and ocular syphilis can occur anywhere at any stage of syphilis. We used to believe it only occurred after someone was infected for 10 or 20 years, when they had been infected for a long time. But it can occur anywhere in primary, secondary, late, or unknown duration. In the treatment, again, the same medication that we use IV for infants that we're treating for congenital syphilis, the aqueous crystalline penicillin G, but in adults, it's 18 to 24 million units per day, administered as 3 to 4 million units IV every 4 hours for a total of 10 to 14 days. If you think that your individual also has late unknown duration syphilis, then you can add the IM benzathine penicillin G, also known as bicillin, to give a complete 21-day course so that you're covering the late unknown duration syphilis. Do we think our individual who clearly has neurosyphilis and ocular syphilis, do we think they also have late unknown duration syphilis? Absolutely. This has been going on for at least 2 years now. So you would most likely want to give this mom that extra dosing of the bicillin or benzathine penicillin G IM. Alternative treatments, again, just like the infant where you can give the procaine penicillin, you can give procaine penicillin IM, and you can treat it as an outpatient. This is really in the situation where you believe that that individual will follow up with you. Or sometimes patients just refuse to come in the hospital, and I've used this treatment to treat them in those situations. However, with an adult, you also have to add probenecid, 500 milligrams orally 4 times a day at the same time that you're giving them the procaine penicillin. And the reason for the probenecid is that it increases the delivery into the kidneys for an adult when you're giving them procaine penicillin. And another alternative is ceftriaxone, 1 to 2 grams IV or IM daily for 10 to 14 days. In light of the fact that we have had a penicillin shortage, we've reviewed the data on this. And I think that our team would recommend if you're going to do 1 gram of ceftriaxone, you should do it for a full 14 days. If you're going to do 2 grams, you can probably get away with the 10 days. So the individual is admitted to the hospital. She receives 14 days of IV aqueous penicillin, and then she gets a bicillin injection on the day that she's discharged. So she gets her full 21-day coverage. She returns 3 weeks later and looks like this. So unlike the otic syphilis, where the hearing can be lost and either recover a little but not fully, ocular syphilis can often fully recover. Now, I've seen it take up to 2 years to fully recover, but it can fully recover. So remember, what about the father? So the second infant's father is incarcerated. The jail does routine syphilis, HIV, Hep C screening on intake, fortunately. So the father gets tested, they're TPA reactive, and TPA is a EIA or CIA test. They're all the same, depends on your lab. Most labs I've seen in hospitals call it a TPA, and the RPR was 1 to 8. So what is the stage on the father here, and what treatment should he receive? Right. We don't know how long, at least from the information I've given you, we don't know how long this father has been infected. So you would assume that this is late unknown duration syphilis, and therefore how many doses of benzathine penicillin G, also known as bicillin, does this father need? 3 doses, yeah. Ideally, 7 days apart. And so again, this father is in the late unknown duration. And I think we've already talked through, if we thought it was primary or secondary, it would be 1 dose, but with late unknown duration, it's 3 doses. And again, this is the bicillin or benzathine penicillin G. And this is just a reminder to be very careful, especially right now when we're in the middle of a penicillin shortage. You see these 2 penicillins, the bicillin CR and the bicillin LA. Bicillin LA means long acting, and that's what we use to treat syphilis. The bicillin CR is actually a combination of long acting and short acting. And if you use that, you're going to inadequately treat anyone for syphilis, whether it's a 1 or a 3 dose. So be really careful and avoid the bicillin CR. And the tricky thing is it's cheaper than bicillin LA, so clinics will often buy it because they can actually afford it. And notice even the syringes look exactly alike, minus that CR versus LR. So be really careful and just, if you're visiting clinics, ask them to show you their penicillin so you can make sure that they've got the right stuff. So why are syphilis cases and congenital syphilis cases on the rise? Well, there are barriers that remain, and I believe that one of the biggest barriers is what we've just showed you today, that patients repeatedly go in for healthcare with symptoms and they are misdiagnosed. They're thought to have, like Wyatt showed you, they're thought to have herpes when they actually have primary syphilis. They miss that secondary syphilis presentation. And we literally have 2 to 3 generations of providers who never saw syphilis in their career until just the last few years, if they even recognized it when they saw it the last few years. I always love to tell this story. When I went to medical school, which is many years ago now, but when I went to medical school, when we had our syphilis training, we were told that syphilis was over. We did not have to worry about it. We would never see it in our career, but they were just teaching us about it just so we were aware. Even after my medical school, when I went to residency, we literally saw less than a handful of patients with syphilis. From there, I went on. I was an HIV doc for almost 30 years. And we tested our patients quarterly for syphilis. We would rarely make a diagnosis of syphilis in those patients until about 2012, 2013. And then we just started seeing syphilis on more and more cases of syphilis. And I can tell you at the time I was running a HIV testing program at LA County USC, right in the heart of Los Angeles. And we would diagnose 10 to 15 patients with HIV in that emergency department every day. And roughly a third of those would have syphilis. And a third of those would have neurosyphilis. So we saw tons of syphilis. And now it's gradually making its way north, which is why you all are starting to see more and more cases up here. So to me, that is one of the biggest issues, is if you don't know, think about syphilis, get it on everybody's differential diagnosis up here, and have them test if they have even an inkling of suspicion, or if they don't know what's going on with the patient, because syphilis, as you've probably heard, is the great, mimicker. So it can present like anything. Next, we've already talked about the fact, some of the other barriers are the fact that the cost of penicillin is cost prohibitive. There are clinics, particularly clinics that tend to care for patients who are more likely to present with syphilis. They cannot afford the bicillin. It's too expensive. It's literally $1,000 a dose. And so you can imagine if you have to treat somebody for late unknown duration syphilis, that's $3,000. That breaks the bank of clinics that are taking care of individuals that are often presenting with signs and symptoms of syphilis. So, you know, the bicillin delivery systems are critical. Supporting clinics, FQHC, free clinics, homeless clinics, because they truly cannot afford to buy syphilis. And then what happens? They can't afford to buy it. And the providers then are less likely to test because they don't want to make a diagnosis for a disease that they cannot treat. And, you know, although you can treat non-pregnant people with doxycycline, and certainly that is an alternative and one that we are using more now because of the shortage, but nonetheless, the ideal treatment is still, to our knowledge, the penicillin over the doxycycline. So that is a huge barrier. One, provider knowledge. Two, the fact that clinics can't purchase it. The third is that we have had 2 international penicillin shortages since, I say here 10 years, but really the last one was in 2015-16. So really it's been in the last 8 years. So obviously if you don't have penicillin, it's harder to treat. You know, it's much easier to give somebody a dose and send them on their way if they have primary syphilis and know that you've covered them, than to give them a prescription of medications they have to take for 14 days. Not that I wouldn't do it, but it's certainly easier to just be able to give them a dose and know that you've got them covered. In pregnancy, part of the issue, as you've seen, is that individuals have delayed or no prenatal care. And again, because of this bicillin issue, the cost of it and the shortage, bicillin is the only treatment for syphilis in pregnancy, or penicillin is. And then add to that these complex social determinants of health. We already saw this mom get her baby taken away from her. So there's those kind of issues can surface. Our mom is now homeless, right? She's living under a bridge and she's using meth. So our data from California has showed that upwards of 50% of individuals who deliver an infant with congenital syphilis are using methamphetamine, and 29% are homeless, and roughly 4% have been incarcerated. So we really have to meet patients where they are to ensure that we give them the treatment they need. Only 16% have had adequate treatment, 22% inadequate treatment, and no treatment, 29%, or late treatment. Again, late treatment is they didn't get that first dose more than 30 days prior to the day they delivered. And that's the day they delivered, not their estimated delivery date, right? It has to be before the day that they delivered. Additionally, when we've asked pregnant individuals with syphilis additional questions, we've learned that other barriers, so Wyatt already shared with you that roughly 25% are accessing care through the emergency department. So emergency departments are a critical place to find, identify, and treat these individuals. But they are also accessing social services about 16% of the time. So your WIC office, your other homeless services office, your housing offices, those are places where you can find these individuals. And, you know, if you need to, bring them in the car and give them their dose right there, whatever it takes to get them identified and get them treated. Other reasons, we saw this with our patients, the doctor maybe makes the diagnosis, but they don't treat it. They refer them on. So that happened in the emergency department, right? They made the diagnosis, but they referred them to OBGYN to get their treatment. The ideal situation in emergency departments is you get that result back right then and there, which is possible. There are labs that can turn it around in 45 minutes. And you treat empirically based on a TPA in an emergency department. The WHO now recommends empiric treatment for anyone who's pregnant who has a positive TPA, so that you get them their treatment. Because you've seen these individuals will disappear. Sometimes they're just simply not aware that they're infected, so they don't know they need medication, so they don't show back up. So make sure you do good patient education. We've heard about a lot of cases in California when we meet with other local health jurisdictions, where it's because the patient finally understood what was going on that they were sure to come back in and get the treatment they needed. Transportation, not as big a barrier as we tend to think it would be. Only 6% said that transportation was an issue. So either go to those individuals and do the testing and treatment there, or go and pick them up and bring them in. But I can tell you, often it's much more successful to just do it in the field. So does treatment work? Yes, you can cure syphilis. And in pregnancy and with congenital syphilis, if an individual is treated early in their pregnancy, greater than the 30 days before they deliver, it can prevent over 90% of CS cases. And then the enhanced case management, if you add that, you can ensure treatment for individuals as well. So, in summary, Wyatt covered the syphilis and congenital syphilis epi here in California. He walked you through both the classic and the atypical primary presentation of syphilis. Again, the classic, a single chancre with raised rubbery borders. The atypical, multiple ulcerations, may or may not have those obvious raised rubbery borders. The classic single is often painless, where the multiple is sometimes painful or slightly painful. Then the secondary syphilis rash, which often is missed, a diffuse macular rash that involves the palm and soles. Sometimes on the palms and soles, those lesions can actually look a little target-like. So be suspicious for syphilis. And in my experience, the rash often looks like it's actually coming up from underneath the skin, like you see it almost surfacing from underneath the skin. They can also have mucus patches, the patchy alopecia. So any of those atypical findings, and don't forget condyloma lata. So condyloma lata, typically flat in appearance, versus condyloma, which is typically verrucous cauliflower-like in appearance. So condyloma lata, think syphilis. And if you're not sure, think syphilis. Then there's late or unknown duration. So either you don't know how long the person's been infected, or you know it's been more than a year. That's late, unknown duration. Any kind of neurologic presentation, syphilis should be high in your differential. Ocular, again, early presentation is often just a conjunctivitis, but it can progress, involve all areas of the eye, and can result in blindness. Don't forget that atypical but rare bluish pupil. And then the otic. Ask all of your patients that you've diagnosed with syphilis, are they having any decreased hearing? Because that is your first tip off that they're heading towards neurosyphilis. And it can be subtle. We talked about congenital syphilis. You have the algorithm. It's available online. It's also available back there in paper. But I understand if you just Google CDPH congenital syphilis algorithm, it'll pop right up on Google and you can have it electronically. We talked about the traditional and the reverse algorithm. Remember, if you've got a positive TPA or a positive TPPA and a negative RPR, you need to do that other test. You need to do if you have the TPPA positive and the RPR negative, then do a TPA, or also known as EIA or CIA. Vice versa, if you have a TPA positive, also known as CIA or EIA positive, and RPR negative, then you need to do the TPPA. You need to do the complete reverse algorithm before you say that patient does or does not have syphilis. We've extensively talked about the different treatments for primary and secondary. It's benzathine penicillin G, also known as bicillin. For neurosyphilis and for infants with congenital syphilis, it's IV aqueous penicillin. Then follow-up testing. Generally speaking, if you just remember to test both infants and adults every 2 to 3 months after you've treated them, and then you're watching for that 4-fold decline, but you want to continue to treat because many will go to non-reactive, but we're satisfied if they at least have a 4-fold decline. And then don't forget about the partner. Always test the partner or have somebody else test the partner. And with that, we'll stop.
Any questions? These HIV testing of infants being evaluated for congenital syphilis.
Yes, remember that the best tests we have right now for HIV, test for HIV antibody antigen, but there's still anywhere from 10 to 21 day window from the time that an individual is exposed to HIV from when the antigen antibody test will become available. So if mom got the test and was negative on an antigen antibody test, then it's still, but they actually got exposed and they're in that window period, it's still possible for them to have transmitted it to their infant. The other thing is that there's a lot of co-transmission of HIV and syphilis together. And so we encourage that you do HIV testing on infants that you're testing positive for syphilis as well. Yeah, I don't know if that answered your question or.
And then one last question for individuals with cognitive issues as a result of neurosyphilis who might refuse or not comply with treatment, what options are available to assist patients in treatment?
Okay, yeah, let me just go back to the infant. For the infant, when you test them for HIV, you're actually doing an HIV viral load. So the infant doesn't get that antigen antibody test because the antibody can be positive for mom for 18 months. And so you just do the viral load on the infant. And it's done at birth at 10 to 21 days and then around 2 to 4 months. So yeah, what do you do if you have someone with altered mental status and you want to test them for syphilis? Was that the question?
Or treat them.
Yeah, or treat them for syphilis. Yeah, so you know, much like other patients with altered mental status, syphilis can be a part of that. HIV, cryptococcus, meningitis, there's all kinds of opportunistic infections that can be a part of it. So often when someone's altered, you know, as long as you have a second clinician who's really supporting you in doing that testing, they agree that those could be some of the potential causes, then you can go ahead and do the test for syphilis or for HIV. Can you go ahead and start treatment on someone who you confirm has neurosyphilis? Can you ask the question again? I'm not sure I'm fully answering the question.
For cognitive issues as a result of neurosyphilis who might refuse or not comply with treatment, what options are available to assist patients in treatment?
Okay, yeah. So if you have an adult who has neurosyphilis but has cognitive delay but is not altered in that they can't, you know, communicate with you, I would consider that the altered individual, but they have cognitive delay and they're refusing treatment. You know, since neurosyphilis can be potentially life-threatening over time, usually what I would do is first I just sit down and explain to the patient, you know, why I thought they needed treatment. And if they're continuing to refuse, you know, much like you would do with someone who maybe is refusing chemotherapy or something, you probably would want to get a second opinion from either a psychiatrist or a psychologist who could evaluate the patient and make sure that they're competent to make that decision. And then if they're competent to make that decision and they continue to refuse, then ultimately, you know, they have power over their own body. If they don't want that treatment, then at least you've done everything you can to both educate them and ensure that they have the mental capacity to make the decision.
Well, thank you very much.
Oh, of course, yeah. Thank you. And thanks to Wyatt as well.
So just a reminder is you will need to complete the post-course material of the questionnaire to get your CMEs. We did record this session, so we'll be sending that out.